Welcome to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We're excited to be speaking with Dr. Kyle Rehder on Patient-Ventilator Asynchrony today. Dr. Rehder, will you please introduce yourself? Tell us something that you enjoy outside of medicine and about your academic interests related to today's topic.
Great. Thanks very much for having me. Excited to be here. I am, as you mentioned, Kyle Rehder. I'm a professor of pediatrics at Duke Children's in Durham, North Carolina. I am also the Vice-Chair of Education here. Within our division of critical care, I'm the section chief for the PICU side, and I'm also the medical director for professional development for the Duke Center for Healthcare Safety and Quality. So wear a few hats here at Duke and have interests in a lot of different areas. Outside of work, I'm a husband, I'm a father of 2 teenage girls. I enjoy cooking. I enjoy making things with my hands. Finding time to do that is a little tougher, but I've made furniture for the house, for example. So I enjoy doing things like that.
Oh, well, that is so fun and aspirational, really. So, Kyle, you've written extensively about the role of respiratory therapists in the PICU, and you've spent your career at Duke, which is specifically known for its robust RT program. I'd love to ask you, what is Duke doing differently? How did you guys build this program and make it so good?
Thanks for that question. When we're at our best, we allow the respiratory therapists to really practice the top end of their scope of practice. And so we try to support that through a variety of ways. As we've had turnover naturally that everyone's had throughout the country, it's sometimes tough to do that. But things that we've done to try to support that, number one is we have a fairly robust protocol that the respiratory therapists can use, but it allows a lot of leeway and autonomy for them to do things at the bedside. And what that functionally results in, instead of the intensivist directing every aspect of respiratory care and ventilator management, it allows the respiratory therapist to use their knowledge and their expertise at the bedside and then have real discussions with the intensivist at the bedside. And so those discussions, I think, really serve to further elevate care and also support these people in their career such that they really feel like, they're just not going through the motions, but they're able to use their brains and they're able to really use their expertise. So those are things that we really try to build in. And in addition to that, those discussions allow opportunities for education, for continued growth, career development, and those types of things.
I mean, isn't it a theme? Pediatric critical care is a team-based care delivery system, and we need everyone functioning at their highest level. So, whether it be a bedside nurse, respiratory therapist, physical therapist, occupational therapist, we need everyone, functioning at their highest to give the best potential outcome for that child. And I think this is a great example of that being done well.
Yeah, absolutely. When I'm not talking about ventilator management, I'm often talking about teamwork and how we work together as teams. And that was one of the big things that drew me to critical care was that team atmosphere and the interprofessional teamwork that we see.
Yeah. We're so excited to talk about our topic for the day. Before we get there, any conflicts of interest to disclose?
No conflicts of interest.
Wonderful. Alice, case?
All right. So you're caring for a 3-month-old boy who's intubated and mechanically ventilated for respiratory failure secondary to RSV with a superimposed pneumonia. The nurse is calling again, requesting more sedation because their patient is tachypnic and the ventilator is alarming. So there are so many things that could be going on here. A common reason is patient-ventilator asynchrony. So what is patient-ventilator asynchrony? What are we talking about here?
So when I think about, ventilator asynchrony or dyssynchrony, it's the idea of the patient is not getting either a breath when they want it, in the way they want it, or how they want it. And so that all plays into the idea of triggering asynchrony or dyssynchrony at the bedside. We as intensivists can really help improve the patient care, and we can talk about all the different ways that it does make a difference in care, but by making sure the patient's synchronous in terms of comfort, in terms of lung mechanics and everything else.
So we want our patients to be comfortable, of course, but is there another reason we should care more about this? I mean, what are the harms of patient-ventilator asynchrony?
Yeah, so the natural aspect, obviously, as you mentioned, is comfort. And if they're comfortable and synchronous with the ventilator, we have to use less sedation. And we know there's downsides of using sedation, and not only in terms of the long-term effects, but our duration of mechanical ventilation is directly correlated with the amount of sedation that we're using. And that's one of the things that's best shown out through the data. The comfort's not a small thing, but it's not even, I would say, the biggest thing. The biggest thing is protecting the lungs. So if you think about our patients with ARDS, and this patient, has respiratory failure with pneumonia, presumably has poor compliance, has some aspect of ARDS. All of the most impactful papers that we've seen come out in ARDS over the last really 30 years have been about lung protection, whether it be smaller tidal volumes or less pressures, less driving pressures. All of this plays into less mechanical stress on the lungs. And my mantra of a ventilator is a ventilator doesn't fix anything. It only supports the patient to allow them to recover. So it's in itself is not curative. But if we don't manage it well, we only cause further injury, which then inhibits their ability to recover from whatever injury put them on the ventilator in the first place. And so that's why it's so important, really an essential skill, a definitive skill, I would say, for an intensivist to not only know how to manage the ventilator, but to do it well and to do it skillfully. So as we think specifically about that mechanical stress standpoint, when we have asynchrony, when we're trying to move our lungs, our muscles against the ventilator, that's going to increase stress in different ways. And we'll talk about that more as we talk about the different types of asynchrony throughout the rest of this talk.
Oh, absolutely. Well, we certainly couldn't agree more with you. Before we get into the different types, I have to ask, because we're on a podcast, we're saying things, asynchrony or dyssynchrony? What's the situation here?
So I will be honest, I am not 100% sure always which the right one is to use because they're used interchangeably. As I think about that, I try to go back to the prefixes of dys versus a, and I believe we are in the space of Greek language prefixes here as opposed to Latin. Asynchrony means, not existent at all. So there's no synchrony versus dyssynchrony, which means not optimal synchrony. So we probably see both in our units. Some patients who have no synchrony with the ventilator, most of the time it's probably in that dyssynchrony space. That's probably a little bit of a harder word to say, which is probably why we see both used interchangeably.
Oh, well, you can't do better than the classic prefixes.
So when I'm on service and their frontline provider or respiratory therapist gives me a call and says, hey, our patient is asynchronous with the ventilator, that could be so many different things. I usually end the conversation right there and just go immediately to the bedside because sometimes it's so tricky to actually describe what exactly is going on there. Just thinking the big picture, broadly speaking, what are the different types of patient ventilator asynchrony before we jump into the actual individual ones?
So right away, I'll say kudos on your response of you go right to the bedside because that's what you've got to do. You've got to be able to look at the patient, what they're doing compared to what the ventilator is doing, and look at those graphics, which can be really useful, which is a particular challenge for us today on a podcast to talk about ventilator graphics, but we'll certainly do our best. In terms of the types of asynchrony that we see, so I really think of it in three buckets. The first of those is trigger asynchrony or dyssynchrony. And so that's when I want a breath. Can I get a breath when I want it? In this case, the patient, can they get a breath when they want it? The next is flow asynchrony. And so that's how they get the breath. So how fast does it come in? What pace is that? How quickly? All of those things. Am I getting enough flow? So that's in our flow asynchrony bucket. And then finally is cycle asynchrony. So when I want to exhale, can I exhale? And you can imagine it's very uncomfortable to try to exhale against a closed expiratory valve, which is what all of our conventional ventilators use, is that it's just a valve that opens. But if it's closed, you can't exhale through that. Or if the breath goes away too soon, you're still trying to get air, and all of a sudden that support goes away. And so that's your cycle asynchrony.
This is particularly important. So we have three types. One is asynchrony with triggering that breath, getting that breath started. Second is with inspiration or flow. And then finally, cycling between inspiration and exhalation.
Correct. Yes.
If a trainee or your first-year fellow was approaching this for the first time, is there a particular bucket that it usually falls in? Is there one that's more common than the others?
I think in our kids, we often probably see trigger asynchrony the most. And I think that's certainly what the data would suggest in some of the point prevalence studies that have looked at asynchrony in patients. And there's a few different reasons for that. Number one is kids have weaker respiratory muscles than do adults when, everything we use was originally built for adults and then we have adapted it to pediatrics, pretty much everything. The ventilators may not have been built for them. And so we have to figure out ways to make the ventilators sensitive enough for these small breaths and these weak muscles. And if you think about, again, ventilator circuits and such, the proportion of dead space in the circuit compared to dead space in the lung, when they go to take a breath, how much of that is lost because of the larger relative dead space. So all of those things, I think, play into trigger asynchrony, including there's more types of trigger asynchrony.
Oh, absolutely. And definitely the pediatric problem, how to tell when your infant is requesting a breath from the ventilator or the BiPAP machine or something else, right?
Yeah, and while I say, we see it more commonly in kids and there's challenges in pediatrics as there often are, we also know that this is a huge problem in our adult patients as well. So if you have an 18-year-old patient in your unit or even a adult-sized 14-year-old patient, they probably are just as great a risk based on the adult data that's out there.
Oh, excellent. Now, how does the ventilator know when the patient wants a breath in most cases? And then what are the different ways that this can go wrong?
Big question. So we'll start off with how the ventilator knows. So there's different types of triggers, which, the ventilator is a machine. It's looking for a specific signal that says, oh, it's time for me to give a breath. The obvious one is time. If you have a patient who's paralyzed, they're not making any effort at all, or for whatever reasons, they're not making a respiratory effort. Eventually, our respiratory rate that we set will kick in. The ventilator will say, too many seconds have gone by. I need to give a breath. So that's our time trigger. The next one, the one that we use most commonly in the unit, is flow trigger. The ventilator sees the circuit as a closed circuit. No air should be leaving the circuit at any point. And therefore, if all of a sudden flow is moving away from the ventilator, then that must mean the patient is trying to take a breath in the ventilator's view, which is the only thing the ventilator can see is that little pipe coming out. Flow's leaving, it must be going into the patient, therefore I need to give a breath. Most of the time, that benefits us really well. Sometimes that can be a problem. But nonetheless, that's our flow trigger. The next one is pressure trigger. And so in this case, it's the same idea. We have our set PEEP, which should be constant at the end of exhalation. And if that goes down, it means the patient has, in the ventilator's mind, sucked enough air in that it's dropped the pressure. And so therefore, the patient must be trying to breathe. Let me give a breath. That's a less sensitive trigger. So that's why we don't use it as much in peds, because it's hard for an infant, this 3-month-old that we just described with RSV, it's hard for them to suck enough air to drop the pressure. And then finally, we have developed other triggers, and the best example is neurologic trigger. As we think about NAVA, or neurologically, where we have a catheter in the esophagus looking for that electrical signal from the diaphragm, that's going to be an electrical trigger that then tells the ventilator, oh, the diaphragm's contracting, let me go ahead and give that breath.
Excellent. I mean, we have time, flow, pressure, and then neurologic. I don't commonly think about neurologic, think about bedside rounds, but that's a good teaching point there. Since trigger asynchrony is the most common, it might be a good time to jump into the different types. We've already mentioned that pressure trigger is less sensitive. And if we have a trigger that's not sensitive enough, we might have a missed trigger breath. So tell us more about that.
Yeah, so missed trigger is certainly one of the more common ones as we talk about infants particularly, and a lot of our infants who may be weak, whether it be neuromuscular weakness, whether it be myopathy from being in the ICU or other causes. They may not just be strong enough to trigger the ventilator because our sensitivity is not set the right way. So functionally, the patient wants a breath. They try to take a breath. The ventilator doesn't give it. And think about how miserable that would be if you're the patient wanting to breathe and the ventilator won't give you air. That's the patient who's going to be really agitated at the bedside, who's going to be air hungry, who's going to look miserable. You get called to the bedside, hey, my patient's agitated, we need to sedate. We actually just need to give them air. And if we can give them air, we don't have to sedate them. How this looks at the bedside is you will see mechanical effort from the patient, their chest wall moving. You will see that air hunger, but they're not getting a breath every time. And in its worst case scenario, they're not triggering any breaths on the ventilator. So while you see the patient at the bedside struggling, you see the ventilator not giving any breaths between the timed mechanical breaths of the baseline respiratory rate. And if you look at the flow scaler, the flow over time, you'll see little deflections in the flow where the patient's trying to suck in air, but it's not reaching the threshold where the ventilator gives a breath. And so those are things to look for. Occasionally, you may even see a deflection in your pressure scaler as well, where the PEEP may drop a little bit. But again, that's less common in a lot of our small kids.
Oh, so we're at the bedside with this infant. They're, nasal flaring, retracting on the ventilator. You're not seeing that the ventilator breaths are triggered by the patient. How do you start to troubleshoot that? What are your first steps?
Yeah, so the first step is to get your respiratory therapist friend to the bedside and to work through it together. But usually it's just a sensitivity issue. So we try to make that ventilator more sensitive by, if we're on a flow trigger, as we usually are, we'll turn down the minimum flow that is needed to trigger the next breath. And so you have to go into the advanced settings one step further, usually beyond what you're seeing on the main screen, and turn down that flow. And you can turn it as low as possible, looking for auto triggering, which we can talk about if you set it too low. But nonetheless, you'll try that first and see if you can find a place where they're starting to trigger each breath as the patient clearly wants it. And you should see the patient changes in the midst of that, because not only will their respiratory rate go up on your monitor because they'll start now getting a breath every time they want it, but they'll suddenly become much more comfortable because that air hunger starts to get better because they can get the breath that they need. Sometimes, despite our best efforts with flow trigger, we're still not able to capture them. And so that's then the place where I will admit we don't use a ton of NAVA in our unit, but that's a place where I'm going to really turn to that and say, this is a patient who may benefit. Can we see about getting that to the bedside, get that catheter in? If we can just sense that electrical impulse from the diaphragm, that may be the only way that we can get a sensitive enough trigger to give the patient the breath when they want it.
Nice. Do you ever find yourself needing to, and this might not be depending on the brand you use, whether it's Servo, Avita, Bella Vista, do you ever find yourself needing to swap out the flow sensor physically?
I have not come across that, where we're specifically trying to swap out the flow sensor. There have been times where we make all the adjustments that we think we need to make, and we're feeling we're just not making it, and we'll swap out the entire ventilator. It's not for a different brand, it's just for a different one. And then, pull the ventilator away from the bedside and let, us go through a more significant troubleshooting. So there are times where we will do that, and that seems to help. And then we kind of, instead of making the patient suffer through us doing all our troubleshooting, we'll pull the ventilator separately and try to figure out what's going on.
Nice. And the flow sensor, maybe to make it a little more sensitive, you would make it a smaller number, and then to make it less sensitive, you make it a bigger number.
Exactly. Yeah.
Nice.
Yeah. So less flow is needed to trigger the breath.
So we talked about if the ventilator is not sensitive enough to detect that breath and have mistrigger. What if our ventilator is set too sensitively, where it's picking up maybe things that aren't breaths?
Yeah, so this is certainly a risk as you've turned down that sensitivity. And particularly the place I often see this is we had a patient who wasn't triggering. And so we turned the sensitivity down quite a bit. And then we leave the bedside, everything's good, everyone's happy, and then get called back into the bedside because the patient's tachypnic. And you go in, you look at the patient, and they are making no respiratory effort. They are triggering breath after breath after breath, and they are tachypnic on the screen, but they're not working at all. And then you look at the end tidal, and the end tidal has dropped 10, 15 points from where it had been previously. Presumably, they're overventilated now. And I'll ask the nurse, what happened right before? What happened in the last 30 minutes? And they've moved the patient. They've turned the patient, as we absolutely should be doing with relative frequency. And what has probably happened is the patient's developed a leak because that ET tube was seated up against some tissues, and then they moved the head a little bit, and that developed a leak around the endotracheal tube. And so now, if we go back to that idea of flow trigger, you have air that's leaking out constantly. Think back to the ventilator where that pipe leaves the ventilator. It senses flow. It's constantly going out, and we've sent our flow trigger really low so that the ventilator says, oh, they're trying to breathe. Let me give them breath, give a breath, give a breath, and just one after another. And so that's what we talk about with this idea of auto-triggering. In that setting, the ways to fix that, number one, you identify the problem by looking at the patient along with what's going on the ventilator screen. The first thing you can do is see if repositioning the patient helps. If that was an issue, you can try to put a little bit more air in their cuff. You will have to go sometimes back up on the sensitivity now that they're in a different position because they are having a little bit more flow. But if the leak is too big, it may interfere with their ability to trigger the ventilator naturally. And there may be those occasional times that you have to change out the endotracheal tube for a slightly larger tube so you don't have that leak.
Oh, yeah. I feel like this one is kind of fun to recognize at the bedside because the vent breaths, they're yellow, they're shaded in. It's patient trigger, patient trigger, patient trigger. And then you have this infant that kind of looks surprised and keeps on getting these breaths. Definitely can hurt them with that air stacking. It is a good one to identify.
It takes some subtlety, right? Because you're seeing the kid's chest rise, so it kind of looks like the child's breathing, but I feel like you almost have to put a hand on the child's chest and look at the ventilator and see if you can detect any kind of inspiratory effort before that vent delivers that breath.
Yeah.
Yeah, and one of the differences here is the patient won't look like they're in distress. And this is one that's actually easy to go under the radar because the patient may be very calm other than the fast respiratory rate because they're getting plenty of air. And in fact, they're probably feeling a little lightheaded from hyperventilation. And so the nurse may not call you in for agitation. It's only that astute nurse who recognizes my patient's tachypnic and I don't know why and calls you in for that.
Don't astute nurses always make you look so smart? They're the best.
We're so grateful. We're so grateful for them.
Absolutely.
So we talked about mistrigger, talked about auto-triggering. What is delayed triggering?
So delayed triggering is that moment where I want a breath and the ventilator gives me my breath, but it doesn't give it to me fast enough, like right when I want it. So the patient is doing their trigger saying, give me the breath. And then there's just a delay period of time. Fortunately, this is pretty rare with our modern ventilators. The equipment in them is sensitive enough that breath is given quite quickly. And this is not a setting that really we have to change. What it will look like at the bedside is the patient may have that increased effort. They still get a breath with every trigger, but you may see that deflection and flow that happens milliseconds before they finally get their breath. And so you may see a little bit of that on the ventilator graphics. If it is something that we're having with our conventional ventilator and feeling like we can't change if we change our sensitivity or anything else, sometimes this is another case where thinking about NAVA may be beneficial because that electrical signal from the diaphragm is going to be even a little bit quicker than you would see from a drop in flow or a drop in pressure at the airway. And so that's a potential way to help with your delayed trigger.
Oh, nice. What about going down on your flow trigger? So I guess so that it senses it earlier? Is that?
Yeah, so you can certainly try that sensitivity. So increasing your sensitivity, decreasing the flow trigger, if you will. And so that certainly is usually what I try first. And then if I'm not able to capture it that way, that's when I, start talking about, should we get our probe, our monitor out?
Nice.
So the next one I want to discuss is double triggering. I feel like this one always gets noticed. Tell us more about double triggering.
Yeah, and so double triggering, now we're getting into ones that really scare me on terms of the potential to cause lung injury. So if we think about our previous that we talked about, mistriggering, certainly that negative pressure against a closed inspiratory valve certainly can cause stress on the lungs. Auto triggering, there's greater data that talks about the overall mechanical energy put into the lungs. And if you're giving extra breaths that the patient doesn't need, that's extra mechanical injury. But now with double triggering, we're not only giving extra energy, but we're going to end up giving larger tidal volumes, higher pressures, other things that we know are dangerous to the lungs. So this is one that not only do we get called a lot, but I do start to really worry about it as causing injury. As we think about what double triggering is, this is a situation where the patient is usually air hungry and they are taking deep, long breaths to try to get really big breaths. So their inspiratory phase is longer than whatever is set in the ventilator. And so the patient's taking that nice long breath. The ventilator gives a breath, and in the ventilator's mind, if you will, in the computer, reaches the end of the set inspiratory time and opens the expiratory valve and starts to potentially dump the breath. And so the ventilator has moved on and said, oh, we're now to the next breath. But that flow trigger is still sensing the patient is still inhaling. And so right away gives another breath. It's a mismatch between the patient's neurally set inspiratory time and the ventilator's mechanically set inspiratory time. So you'll see on the ventilator, there will be some breaths that are bigger than others, because if you can imagine, the patient has taken that first breath, the ventilator has tried to exhale, the patient has not. They've continued to suck in that air and they get another breath right on top of it. And so you're going to have pressure alarm going off, high pressure, high volume. You're going to see volumes higher than what you've been targeting, that normal 5 to 8 that we're probably shooting for in most of our patients. So that's what it looks like at the bedside. And you'll almost see some breaths where it either just looks like a huge breath, or you may even see a little bit of a gap where it looks like a one breath stacked right on top of the other. And so this is kind of a different type of breath stacking than what we normally say breath stacking, which is an expiratory problem. That's what it will typically look like at the bedside. And generally the way to fix it is to extend the mechanical inspiratory time. So the patient's got this long neurally inspiratory time. And so the way that you're going to fix that is to try to match that with the ventilator. Now, these are often patients who have ARDS, who have respiratory distress. And so they want these long times to try to open their lungs. In the setting of that, they likely don't have obstructive airways disease. I will say broncholytics sometimes can be a real challenge. And so if you have that mix of both restrictive and obstructive physiology in front of you, then it can be hard. But a lot of these patients just have the restrictive component. And so you have the ability to go up on their inspiratory time and still letting them fully exhale. Because the reason they're inhaling so long is they're working against tight, low compliance lungs. And then once they are able to exhale, those lungs are going to empty pretty quick.
Oh, nice. It's not intuitive unless you really understand what's happening, right? Because you get this patient with giant breaths and breath stacking, and that's the concern. And then you stretch out their eye time and then they look better.
Yeah. And sometimes you can also help this by changing the flow into the patient. So we'll touch on this a little bit more with this idea of flow asynchrony that we're going to talk about presumably a little bit later. But at the end of the day, they're taking these really long breaths because they're air hungry. And so if you can give them a little bit more flow in the moment too, that sometimes will help with double triggering and potentially their flow asynchrony that may be jointly happening at the same time.
Nice. Now, before we move into other types, we also have to talk about reverse triggering. So what's happening here?
Yeah, so admittedly, reverse triggering was the one that was hardest for me to grasp as a concept, because what did that really mean? Reverse triggering is a situation where the ventilator gives a breath, And the stretch as the lungs expand, the stretch in the diaphragm actually causes a diaphragm contraction. And so it's a situation where the ventilator is actually triggering the patient to breathe, hence the name reverse triggering, as opposed to the patient triggering that ventilator, which is the way it should work. In that situation, usually there's a ventilator breath immediately followed by a patient breath. And the patient breath is again triggered by that diaphragm contraction. Essentially, I think of it as a hiccup. What causes hiccups? It's other things that may stretch the diaphragm in that setting. Functionally, what it looks like at the bedside, it looks really similar to double triggering because you have a breath immediately followed by another breath without an exhalation in between. However, with reverse triggering, you have a little bit of an exhalation in between. And so as opposed to an immediate stack, breath maybe flattens out a little bit and immediately goes into another breath. If you look at that flow scalar, it'll start to exhale a little bit before that diaphragm contraction kicks in and gives you another breath on top of it. The risk is the same as double triggering, where you have not fully exhaled the prior breath. You give another breath immediately. You have high pressures. You have high volumes. You've got stretch on these sick lungs. And so again, there's risk for lung injury as it's happening. Often the patient's effort, as opposed to double triggering, where you see a patient who's air hungry and taking these big, long, full breaths. In reverse triggering, they're going to get a fairly normal breath that they're probably not working all that hard. And then they get another breath right on top of it that they didn't want, probably. It's that diaphragm contraction. May or may not cause discomfort. But when you look at the patient, the work of breathing is going to be higher in double triggering generally than you will see with reverse triggering. So that's one other way that you can try to tease them out. And it may even be a mechanical breath, if you will, a mechanically triggered breath, not a patient-triggered breath on the first of the two breaths when that happens. So how do we fix it? That's the other question. Generally, I think here, what I'm doing is causing enough stretch on the lungs that it's causing that diaphragm contraction. So these are the patients I say, okay, well, we were targeting 5 to 8 tidal volume. Maybe we actually need to target a little bit lower. We don't need to have as much stretch on the lung. Or again, are we giving the flow so fast that it causes a stretch on the diaphragm? And so try to slow down that flow, increase the rise time, if you will, so that it doesn't come up quite as fast, so that they don't see that immediate stretch on the diaphragm. I will say there are patients, even after you make all those tweaks, that with reverse triggering, that you may need to paralyze. Counterintuitively, you may actually be able to decrease sedation, and it helps reverse triggering as well. In those settings, what's actually going on is you see basically the diaphragm is acting as a reflex. And like any of our reflexes, when we are really out of it, unaware, the reflexes can be a little bit stronger. And so sometimes when you see reverse triggering, before I give in and completely paralyze them or deeply sedate them first, paralyze if needed, I'll actually often try to say, can we come back on sedation a little bit, let them control their breathing a little bit more, and then what we'll see is you don't get those either big breaths or those diaphragm contractions kind of out of the blue. I hope that makes sense.
Oh, yeah, that's very interesting. And this is also the first category where you've mentioned the rise time. Can you explain again what the rise time is and how you're changing it to really focus on this problem?
So that's going to really blend in well where I think we're headed next, which is flow asynchrony. So as we think about flow asynchrony, I mentioned it. Once we have triggered and said, oh, okay, it's time the ventilator's going to give a breath. Once we've triggered that, how does the breath go in? It's how the breath goes in. We have flow pattern, which is it a decelerating flow where it's really fast at the beginning and then slows down, which is the natural way to breathe? Is it a constant flow? We use that a lot more in adults than we do in pediatrics, but we set a exact flow and they get the same flow for the entirety of the breath. Less of a natural way to breathe, but is the way that traditionally our first ventilators actually gave breaths, was this constant flow across the breath. But we can control that flow rate. And then we can also control in decelerating flow, and also now the ability to sculpt breaths when we are in more of a, we're controlling the flow mode. We can change how fast that flow goes in. And so even in decelerating that flow rate, how fast the air is able to go into the patient, we can speed that up or slow it down by changing the rise time. And so that's how quickly the flow rises, if you will. So when we talk about decreasing the rise time, that's actually a faster breath. The gas goes in quicker, as opposed to slower rise time. We're going to let that go in a little bit slower. It's going to make that decelerating flow slowly start to look more and more like a constant flow because you don't have the peak of flow right at the beginning of your breath.
So let's talk about why that is important for patients. So if a patient is, for some reason, has asynchrony during inspiration or flow asynchrony, what's going on here?
Yeah. So if I'm a patient, I want to get a breath when I want it and how I want it. And we have a lot of patients who have a lot of reasons for air hunger. That may be metabolic reasons like acidosis. It may be neurologically driven. And unfortunately, we have a lot of patients in our unit who do have neurologic injury and may have unusual breathing patterns. Or it may just be that I have really poor compliance and I have air hunger because of ARDS and hypoxia. And so therefore, I'm trying to get air fast and a large breath. And so in those settings, I want to be able to get air really fast. Now, we also have other patients who, for other reasons, may not tolerate air really fast. And so as we talk again about obstructive airways disease, if your airways are really tight and you give air too fast, it kind of bounces against those really tight airways and causes pressure spikes and such. And that may not be as helpful. Or even just in normal compliance lungs, if you give it too fast, you still will see a spike in the pressure before the lungs really are able to compensate and expand. So you have to think about things like compliance and elastance and resistance and overall time constants in terms of how fast the lungs are ready to receive that, in addition to what is the patient's inspiratory demand. And at the end of the day, that's what we're really trying to match, is the patient's inspiratory demand with these different flow rates, rise times.
So this is the patient maybe where they have ARDS. You think that they're on appropriate vet settings and you're achieving your goals, and you go to the bedside and they're like working, nasal flaring, tachypnic. Is this someone where you would say, okay, you need more flow earlier and you would start to maybe shorten that rise time? What are your thoughts?
Yeah, so that's exactly it. Is the patient, even if they're getting adequate volumes, they're still clearly not comfortable and they're still air hungry. And so they need some sort of increased support. And often, instead of just going up on your pressures or tidal volumes, it's giving them air earlier in the breath. There's a lot of things that are coming out in the adult world that I think we will see in peds in the future in terms of looking at airway occlusion pressure, or what's called P100, which is the pressure change in the first 100 milliseconds of a breath, that can really start to help us measure and understand the patient's work of breathing. But those at the bedside have seen patients and understand this patient's working too hard. And even without talking about it mathematically, we can see that patient who's air hungry and trying to just get that breath faster. And so in that setting, one of the ways, as we mentioned, we can give them the flow quicker, shorten the rise time, have that flow go up quick. The other thing I look at the bedside when I go up is the pressure volume loop. On the ventilator, anytime you're seeing something that's not a fairly smooth curve or natural looking curve, should raise your trigger of, those hackles on your neck of, okay, I need to figure out something because it's probably asynchrony. And so on the pressure volume loop, you'll actually see a figure 8. So if you can picture this in your head, it normally looks like a little bit of a football shape on its side. And at the beginning of the breath, you'll actually see it go negative pressure before it drops in. And that's because the patient's sucking in this big breath, dropping it negative before the ventilator is finally able to give the flow. That can be seen in delayed triggering, certainly, as we talked about. They don't get the breath as quick as they want it. But more commonly, it's that work of breathing. And that's that patient that you see really just sucking in air before it's finally giving them enough. Changing that rise time, shortening it so they get that gas quicker is going to help decrease that work of breathing, even if you don't go up on support. But sometimes you do need to go up on the support as well and say, okay, this is a patient who maybe needs a little bit higher pressure, maybe needs a little bit higher volume. Sometimes even with the higher pressure, you may not get higher volume depending on the compliance at the upper end of that curve. But nonetheless, that's the patient's way of asking for more help, and we need to give it to them.
If it's not clear already, this can be technically really complex about identifying the source of the asynchrony and what to do about it. This is a conversation that happens at the bedside, in front of the ventilator, in front of the patient, with the respiratory therapist. I just don't see how it could ever be done over the phone, right? Yeah.
Zach, you're picturing me all snuggled up in the call room at 3 a.m. being like, just try the rise time. No, at the bedside.
Yeah. Absolutely. Maybe a place for telemedicine. If you can hold up your iPhone to the screen and then to the patient, we might be able to limp by a little bit with that. But generally I agree, very much at the bedside. Like anything else, once you've done things enough, you can sometimes get a sense and have a suspicion before you go in, but you don't want to have that premature closure on your decision making without actually having seen the patient.
Oh, yeah. Now, you also mentioned that when you're diagnosing, thinking about flow asynchrony, you're also thinking critically about the time constant. Can you explain that?
Yeah, so everyone who's gone through critical care fellowship right now is having horrible flashbacks to some lecture they had during their fellowship about time constants. It's something that's important to understand, but yet we often don't talk about it outside of boards. So time constant is mathematically the product of resistance times compliance. But functionally, I think of it as the half-life of the lung. How long does it take the lung to fill? How long does it take the lung to empty? And that's an important thing, that the way we naturally breathe, we don't fill in a constant way or exhale in a natural way unless we are limited with resistance. So we fill faster at the beginning and then slow down as we reach the end, and the same way as we exhale. It's in a half-life decay, if you will. Exponential decay is what I was trying to say. So with that exponential decay, we conceptually think of the time constant is the amount of time it takes to empty the lung 63%, which is an odd number. But what it means is that we need 4 to 5 constants to almost fully empty the lung. So about 5 constants will get you around 98, 99% empty. As other variables change, our compliance and our resistance, that's going to change our time constant. And functionally, we see this at the bedside. So let's think about obstructive airways disease. Resistance goes way up. So therefore, resistance times compliance, our time constant goes way up. It takes longer to empty the lung. And so we're going to need a longer exhalation phase. ARDS, compliance goes down. And so the lungs are stiffer. They fill faster. They empty faster. They snap back. And so in those settings, our time constant goes down, and we don't need as long to fill and empty the lungs when we have those really stiff lungs.
A patient population that I've personally struggled to help support are those with ex-prematurity, severe bronchopulmonary dysplasia, tracheostomy dependence pretty commonly. And I feel like I really have a really hard time getting them synchronous with the ventilator. I mean, of course, it's heterogeneous and there's multiple things going on. But do you find that it's usually a flow asynchrony with these patients, or is it more complex than that?
It is so hard to make a generalization because every patient can be a little bit different. I still always try to look at trigger first and make sure our trigger is right, because the patients that you just mentioned may have multiple reasons to not have the best trigger sensitivity. So if they have a trach, is it a cuff trach or not? Is there a leak? So are we set up for trigger issues there? Even if they have a leak and are not auto-triggering, which is when we talked about a leak, setting up your situation for auto-trigger, if they go to take a breath and they're getting some air around the trach as they inhale, the ventilator may not sense all that flow. And so the patient may actually be making a good effort and the ventilator doesn't sense the flow and so doesn't give them a breath. When their lungs at baseline are okay before they come into our unit, that may be fine because they still get air, just not through the ventilator, and they get what they need. But as their compliance changes, if they start sucking in a lot of air around the trach, but they really need a little bit of extra pressure to expand their lungs in the setting of illness, that may now become a problem. So I still always have to think about trigger in all the different ways. These patients are often weak. These are, other issues as well that may affect that trigger sensitivity, or they may, have long inhalations in the setting of illness. But then, again, you have to look at flow. And these patients, are they exhaling all the way? One of the other things that can set us up for triggering issues of different points is if we have gas trapping in the lung, and that sets us up for hyperinflated lungs. And so the diaphragm is not going to work as well under those conditions. And it may change our ability to trigger the vent. It may change how we flow gas into our lungs. So treating bronchospasm, making sure that we're fully exhaling are still going to be important factors, not only for lung protection, but also for ventilator synchrony.
Wonderful. I feel like we've talked about trigger asynchrony and flow asynchrony. Shall we get to cycling asynchrony?
So before we move on to cycling asynchrony, we talked about the situation where we have inadequate flow, which far and away is the situation that we see most commonly. We have patients who have sick lungs. They have that high inspiratory demand. We do have situations, though, as their lungs get better, we have set them up where we were treating them when their lungs were sick, and now they're in their weaning phase, and we're giving them too much flow. And so specifically, what we'll see is we've shortened that rise time to give them the support they need while they're sick. As they get better, now their lungs don't need that same rapid flow because their demand is not as high, but yet we're still giving it to them that way. And so in those situations, once again, you may be called to the bedside for high pressure alarms because that flow goes in so fast, faster than they need it. And if you look at the pressure scaler, you'll see a little spike right at the beginning of the breath before it settles out with what your target pressure is or the target volume is. And so that's a situation where we actually need to back off on our rise time. We need to lengthen the rise time because of the fact that we're giving them too much support. So much less common in our unit, but I think it's at least still worth mentioning given that both you can be called to the bedside because of pressure alarms and the fact that that's another place during the weaning phase where we could still be causing lung injury.
Oh, yeah, absolutely.
Shall we jump into cycling asynchrony when there's this issue with timing between inspiration and exhalation?
Absolutely.
So our first one that I see here is premature cycling. What does this look like at the bedside?
Premature cycling is the idea of I'm getting a breath and the ventilator dumps it too quickly. So often, again, these patients who are sicker, they have, this high demand. They're still inhaling, trying to get that air, and we've set the inspiratory time so short that we cut off their breath before they're done. On the ventilator graphics, what you'll see is on your flow scaler, if you are in decelerating flow mode, which is, again, what we're going to be using most commonly, you'll see that the spike at the beginning of the breath, you'll see it coming down in its normal pattern that's a kind of an exponential decay, and then it all of a sudden drops off suddenly when you're at, say, 50% or 70% of whatever your peak inspiratory flow was. That's a good sign that we're cutting off the breath too quick while the patient was still trying to inhale. While they were slowing down their inhalation, they weren't completely done yet. And the patient will be uncomfortable. They'll be agitated. They'll have increased work of breathing because they're not getting a full breath when they want to get a breath. The ways to help with that is, number one, obviously you can increase the inspiratory time, or you can also may just need to increase their support. So if you increase their total pressure or volume targets, they may be able to get that breath a little bit quicker in terms of what they need. So if you are, say, in a constant flow mode, you can give a higher flow rate. Similarly, sometimes if you just put these patients in pressure support with a higher support, that allows them to control their inspiratory time instead of you controlling it through the ventilator. And anytime you can give the patient more control, that's generally going to make them more comfortable as long as you can achieve what you need. The flip side of that is you may see these patients turn into kind of guppy breathing, these really fast breaths. And so assist control can also be a treatment for this. So if you switch them into assist control mode where you control the inspiratory time for every single breath, but lengthen it so that you make sure that they have enough time, then that's going to help with that situation of premature cycling.
I was going to interject earlier in our conversation. Me as a early career attending, sometimes these subtleties of what's causing asynchrony is not clear. But if you have a patient with a good respiratory drive, putting them in a spontaneous mode of ventilation usually fixes most of these.
That is absolutely true, yeah.
How often do you flip your kids into pressure support? It feels like a silly move, but I've definitely tried it when I'm at the end of my rope with other things and the kid's not that sick. What's your clinical practice here?
I will probably try to lean that way more often than not when I see asynchrony. And so we've talked about a lot of the nuances of how you can fix things without changing modes. And I should have probably brought this up earlier, is a lot of these you can fix, because the nice thing in pressure support is you may need to increase the support to give them the air they need in the setting of air hunger. They're going to set their own inspiratory time and expiratory time and things like that, which are just going to be naturally more comfortable, and you're going to rely on their trigger. The biggest pause I have from using pressure support, obviously, if we have patients who are in heavy sedation who may be going in and out of apnea, then we may just be flipping in and out of it. But the other place that I worry about is the small babies who can get really tachypnic. They may shorten their inspiratory time so much with these little panty breaths that they start to not maintain their mean airway pressure in the same way and ultimately set them up for atelectasis. And specifically, the babies who are likely to breathe that way and set up for that have other reasons for atelectasis in terms of their overall chest wall and chest wall compliance, in terms of some of the smaller airways, developmental things that happen over time in terms of channels between the alveoli and the bronchioles. So that's the place where at least gives me a little bit of pause. But in terms of while I'm troubleshooting, that's often an early move, is while we're trying to figure this out, let's put them in pressure support and see what they look like when they're fully controlling their breathing.
Yeah. Maybe if you've got like a couple school-age kids on SIMV, pressure control, pressure support, 30/10 rate of 28, and you're dealing with them, is that a situation where we would come in the morning after your call and one of them would just be in pressure support?
Potentially. So I think you said their settings were 30/10. And so that's a patient who's on quite a bit of support. That one, I'm going to be watching closely if I'm switching them on pressure support, because I want to make sure they're getting what they need. And even on pressure support, I'm worried about the amount of work of breathing that they're going to have. I didn't use this term earlier as we talk about why synchrony matters, but it certainly plays in a lot, is this idea of PSILI, so patient self-inflicted lung injury, which I think we're still understanding in kids, but, does truly seem to be a real entity. And this is the idea where we are doing safe things with the ventilator, and pressure support mode on reasonable pressures is a safe thing with the ventilator. but yet the patient still is doing things that are injuring their lungs because of their high respiratory drive. And so they're taking these really big breaths, or their tachypnea is so fast that it's just putting a lot of stress on the lung. And so I do worry about that more. If you have that patient who's on high support, that will still give me a little bit of pause about putting him in pressure support and just leaving him. But if we have a patient who's clearly in the weaning phase and is now starting to see some asynchrony, but we've been coming down on their settings, that's absolutely a patient where it may come in and find that patient on pressure support.
Nice.
So we were talking about asynchrony with cycling. We talked about premature cycling, where that vent ends that breath a little too early for the patient. On the other end of the spectrum, you have delayed cycling. Tell us more about this.
We have the flip situation now. So you had that patient who was really air hungry, who was taking these big breaths. And so you were having premature cycling. So you went up on your I time. And we'll say, for the example, we put them in an assist control mode. So we were controlling their I time with every breath. And we needed a longer I time to match what their need was, their neurally set I time was. And so now they've been in the long I time, but they've changed, as our patients do. Their physiology changes in front of our eyes. They're in a different place now. And so this patient, as we talk about cycling asynchrony, can I exhale when I want to exhale? They want to exhale and the expiratory valve is still closed. So they are trying to exhale against that closed valve. And so in that setting, again, it's not comfortable. It's not a natural way to breathe. Their muscles are contracting against a closed valve. So that's increasing pressure and stress within the lung, which can be a problem. Functionally, what it will look like at the bedside. If you look at the flow scaler, so the flip side with premature cycling, we said we saw that decelerating curve having inspiratory decay, and then it cuts off short. In this setting, we'll see the full exponential curve hit all the way down to baseline, and then the flow scaler stays at 0 for seconds before we finally let them exhale. A lot of the things we're talking about are pattern recognition, and that's a good pattern to recognize. When I go in, is inspiratory flow done, and do we let them exhale right away, or is there that pause? There may be occasional times where that pause will help you if you're trying to recruit lung and trying to increase your mean airway pressure. There's times that I may use that to my advantage very purposefully, but that's usually in the patient in the acute phase of their illness who is still really sick, who probably is going to be more heavily sedated. Once they're in the weaning phase, I want to really time that up so that as soon as they're done with their inhalation phase, the expiratory valve opens, they're able to exhale. In that setting, what you've done is we've set our inspiratory time too long. We just need to bring that down. And this is the perfect example of where I will flip them into pressure support. Absolutely. I won't even usually mess with the inspiratory time. I'll be like, okay, let's just put them in pressure support. Let them set their own time as opposed to keeping them open too long. Unless, of course, I'm doing it purposely to increase their mean air pressure and recruit.
Yeah, that's a great hack. I think our units are about to see a little more pressure support.
I think that's probably not a bad thing. The biggest thing that you'll have to watch for is that flow asynchrony. Are they getting enough support for what they need? That'll be the biggest thing to watch for with your acutely ill children.
This has been a great conversation. You have patient-ventilator asynchrony. If you keep a close eye, you can detect it every shift you're in the pediatric ICU. And, we might not get as excited about like septic shock and ECMO and all that good stuff. Like, this is so practical and it's so important for patients and even for families to see their child struggling on the ventilator. If you can go in there and make some fine-tuned adjustments to make their child more comfortable, it's a big deal for families and patients.
Yeah, I mean, absolutely. And at the end of the day, our goal as intensivists is to get the patient off the ventilator as soon as possible. And if asynchrony is hurting us from doing that, either in terms of injuring the lung further or making us give the patient more sedation and or paralysis, all that's going to keep them on the ventilator longer, which is not what we want. And so optimizing synchrony is going to help us achieve our goals of moving them forward. And it's something we don't talk about as much as we should. There's been at least 2-point prevalence studies done in the last few years looking at kids in the ICU and shows that about 1 out of every 3 breaths is asynchronous in some way.
Wow.
And so if you think about 1 out of every 3 breaths, but yet how much time do we actually spend thinking about this and talking about it at the bedside?
Yeah, we're scoring a 66 right now.
Yeah.
It's not great. Well, Dr. Rehder, thank you so much for joining us today. As we wrap things up, is there anything you'd like to emphasize for the listeners or have them check out?
Absolutely. The thing I'd love to emphasize is exactly what you all brought up earlier, which is when you're worried about asynchrony, go to the bedside, look at the patient, look at the ventilator graphics, pull in the respiratory therapist to be at your side so the two of you can look at this together. Because realistically, you're not going to be at everyone's bedside, and the respiratory therapists are going to be focused on that while you're dealing with other things. And so that they're seeing what you're seeing and that you're on the same page. I think that is absolutely the best thing. And this is something you should pay attention to on all your patients, because we talked about the idea of pattern recognition. Once you see things enough, then you can recognize it quicker and you know how to treat it quicker. And so just that awareness of asynchrony is a real problem in one of my patients in the unit right now. And all my patients are having some asynchrony. So I need to be looking for it continuously. Those are two of the big things I would highlight. The other thing is just the future directions. How is this field evolving and developing? There's a couple things that I would highlight. I think the ability to continue to understand how we can best use NAVA, not only on the triggering side, but also understand work of breathing, looking at that electrical impulse of the diaphragm and what signal is it giving us. The thing that we didn't talk about today, which is esophageal manometry and using those balloons to really help understand triggering. I think there are some places who do that really well and more frequently than others. I will admit it's not something that we use a lot in peds, and there are some challenges in terms of not only the equipment, but patient sizes and such. But again, that allows us to see what's going on inside the patient and with the diaphragm. And so it's something that I hope that we'll see that we'll use more and that pediatric intensivists will really continue to understand. And then some of those other things I mentioned, developing in adults around airway occlusion pressure, and also that P100 of how fast does pressure change within the lung in that first breath, which will tell us about the patient's demand so that then we can match that. But again, the take-home points, look for it, go to the bedside, look at the patient, look at the graphics, include your respiratory therapist in the discussion. And if we do those things, I think we can really achieve better outcomes in our patients.
Wonderful. It's been a real pleasure having you expertly walk us through this topic. We're so excited to share it with our listeners.
Well, thank you so much. Thanks for all you do with the PedsCrit podcast. You all do a wonderful job.
Alice, I might ask you one more question. Sometimes I find when we don't correctly identify the source of the patient-ventilator asynchrony and give unnecessary sedation, I find it triggering.
The Cohen children's family is going to laugh at this episode because I do get revved up when we can't figure out the patient-ventilator asynchrony. I find it very triggering.